Hello, everybody. Welcome to the new series of endocrine system. So, uh, in this first part of our endocrine series, we will deal with endocrine foundations and basics of endocrine system. So, in this video, we'll be covering foundations. Before beginning with the video, I would like to ask everybody and request every one of you to please subscribe and keep supporting. This is an open access lecture series is provided free. If you find it useful and wish to support its development, you can contribute voluntarily. The link is in the description. You can pay with any of these payment methods. Uh, Before we start endocrinology, I want to address why this subject feels difficult to most students. It's not because endocrinology is complicated, but because it is often taught as you know, isolated facts and hormone lists. To be honest, USMLE does not test memorization of hormone names. This exam tests mechanisms, receptor logic, patterns, signaling pathways, and feedback loops. In endocrinology, every question can be broken down into one simple flow. It's like from the hormone to the receptor, the pathway, the effect, and clinical picture. So in this video, we are going to build the foundation so that all endocrine questions start feeling logical and you can predict them rather than just getting confused. So to begin with, what is a hormone? A hormone is a chemical messenger that is released into bloodstream and acts on distant target cells. A very important concept to remember is that these hormones, do not act on all the cells in the body. These do not act on all the cells in the body, but they act on cells that have a specific receptor for that hormone. So if there is no receptor, there is no effect. This means that the presence of a hormone does not alone guarantee an effect. If the hormone receptor is missing or if the receptor is defective, the hormone will not work. So this idea explains why many endocrine diseases where hormone levels might be normal, but symptoms are still present. Okay, so every hormonal effect in the body depends on the same three steps. First, the hormone is released into the bloodstream. Secondly, the hormone binds to its specific receptor. And thirdly, an intracellular signaling pathway produces a final effect, hormone secretion into the bloodstream, receptor binding, and thirdly, intracellular signaling pathway that will finally produce an effect. So it is very important to understand that hormone level alone does not determine the effect. The receptor and the signaling pathway, as we've already discussed, are important in producing an effect. Receptor and signaling pathway together they produce an effect. This is why the same hormone can produce different effects in different tissues and different defects cause different diseases even when hormone levels are normal. So same hormone can cause different defects in different tissues and same disease may present with different lab patterns. It's like uh, the same hormone may cause different effects in different tissues, and also a receptor defect causes different kinds of diseases even when hormone levels are normal. So this logic repeats across all endocrine systems. Hormones are classified based on their chemical structure, and this classification predicts how they behave. So it could be peptide hormones, steroid hormones, and amine hormones. Protein and peptide hormones, such as insulin, ADH, growth hormone, and ACTH. These are all water soluble. Insulin, ADH, growth hormone, ACTH, all these are water soluble. These water soluble hormones cannot cross the cell membrane and therefore acts through cell surface receptors. Whereas steroid hormones such as aldosterone and estrogen, so all these hormones are lipid soluble. Cortisol, aldosterone, estrogen, and testosterone. So all these hormones are lipid soluble. They can cross the cell membrane, and because they can cross the cell membrane, they act through the intracellular receptors, unlike peptide hormones, which act through cell surface receptors and they cannot cross the cell membrane, whereas these steroid hormones can cross the cell membrane and also act through these intracellular receptors. So amine hormones are derived from tyrosine. These catecholamines behave like peptide-like hormones, whereas thyroid hormones behave like steroid hormones. Okay, so in amine hormones, so all these amine hormones are derived from tyrosine, and these amine hormones includes catecholamines and thyroid hormones. Catecholamines behave like peptide hormones, whereas thyroid hormones behave like steroid hormones. So now let's try to understand why classification matters. Peptide hormones act quickly, they have a fast onset and have a short duration of action. These peptide hormones are stored in vesicles and they act through secondary messengers or second messenger system. So these peptide hormones have fast onset, they are shorter duration of action. These are stored in vesicles and they act via second messengers. Whereas steroid hormones act slowly, they have a slow onset, but have long-lasting effect. They act for a long duration because they alter gene transcription. They have a long duration of action because they alter gene transcription rather than just acting as second messengers. These steroid hormones alter the gene transcription, so although they have a slow onset of action, they have a longer duration of action. These are synthesized on demand rather than being stored as in peptide hormones where they're stored in vesicles. These steroid hormones are synthesized on demand, but they're not more often stored. In USMLE questions, so these rapid effects usually points towards peptide hormones, while long-term adaptations like chronic effects points towards steroid hormones. So examples include glucagon can correct hypoglycemia quickly. Glucagon can correct hypoglycemia quickly, whereas cortisol helps the body to adapt to chronic stress. So this glucagon being a peptide hormone, it acts and corrects hypoglycemia very quickly, whereas cortisol being a steroid hormone, it has a slower onset of action and longer duration of action. It helps the body to adapt to chronic stress. Where do hormone receptors live? So these hormone receptors are located in two main places. One, on the cell surface, and the other one inside the cell. So these water soluble hormones use cell surface receptors. These water soluble hormones use cell surface receptors because they cannot cross the cell membrane. So these water soluble hormones do not cross the cannot cross the cell membrane, so they use the cell surface receptors, whereas lipid soluble hormones use intracellular receptors because they can enter the cell. They can enter the cell. So this single concept explains most endocrine questions. So it's like, so the cell surface receptors are used by water soluble hormones, whereas intracellular receptors are used by lipid soluble hormones. So cell surface receptors are used by peptide hormones and catecholamines. Catecholamines we have discussed. They're amine They're amine like hormones. They're amine hormones. So catecholamines behave more like peptide hormones, uh, whereas thyroid hormones behave more like steroid hormones. So the cell surface receptors are used by peptide hormones and catecholamines. So these hormones binds to the receptors on the cell membrane, and a second messenger system carries the signal. So there's an intracellular signaling cascade which carries the signal inside the cell, which initiates a rapid cellular response. So the key features or the key effects include that it is rapid. It has a very fast onset. This has a short duration of action. The effect is very much short-lived with cells with peptide hormones and catecholamines. The effect is short-lived, but it has a rapid onset of action. So, this is why. So these effects are rapid and short-lived, and these effects are reversible. So whenever there's a mention of immediate effects in a question, think of a cell surface receptor. So intracellular receptors are used by steroid hormones, thyroid hormones, and vitamin D. These hormones enter the cell. These hormones enter the cell and binds to its receptor, and then it directly alters gene transcription. So these intracellular receptors are used by steroid hormones, thyroid hormones, and vitamin D. They cross the cell membrane, they binds to intracellular receptors, and then they alter gene transcription. So the effects are slow to begin, but they last for a long time. So if a question describes delayed but sustained effects, we need to think about intracellular receptors. So receptor location explains why hormone resistance occurs. So we need to understand that whenever we ask ourselves a question why receptor location is important, you need to understand that receptor location explains why there's any kind of hormonal resistance occurring or developing. So a patient may have like normal or high hormone levels, but they can still have symptoms if the if the receptor or the signaling pathway is defective. So you may see patients whenever you do a laboratory evaluation, a patient might have normal hormones or high hormone levels, but they still have symptoms of deficiency. So why is this occurring? Why is this occurring? Because the receptor or the signaling pathway might still be defective even though the hormone levels are uh, proper and within the range. So, so the classic example of this is insulin resistance, where insulin is present, but it does not produce its effect because there's there's receptor resistance. So drug actions depend on the receptor type. Normal labs plus symptoms, we have to suspect receptor or signaling pathway defect. Introduction to second messengers. So second messengers are intracellular molecules that transmit intracellular molecules. These transmit signals from the hormone and receptor interaction to inside of the cell. Hormone and receptor interaction to inside of the cell. So they exist because hormones cannot enter the cell. So these second messengers exist because hormones cannot enter the cell, but signal must be transmitted inside. So hormones stay outside the cell, but signal must be transmitted. So what can be done? So in evolution, what happened is our body developed second messenger systems. So the major second messenger systems that are tested includes uh, cyclic AMP, IP3 or DAG, tyrosine kinase, JAK-STAT, and cGMP. So the pathway is the hormone goes and attaches to the receptor, most probably a cell surface receptor, and there's a second messenger pathway that initiates a cellular response. The cyclic AMP pathway is the most commonly tested endocrine signaling pathway in the USMLE. So, uh, after hormone binding, the G protein activates adenylyl cyclase, which produces cyclic AMP. After hormone binding, the G protein activates adenylyl cyclase, and this adenylyl cyclase produces cyclic AMP. Cyclic AMP then activates protein kinase A. So hormone binding, G protein is activated, adenylyl cyclase is activated. After adenylyl cyclase is activated, there is production of cyclic AMP. This cyclic AMP activates protein kinase A, which leads to a cellular response. So uh, if unsure about a pathway, you need to understand that cyclic AMP is often the correct answer. So whenever a question comes on your USMLE or NEET PG, whatever it might be, because cyclic AMP is the most tested on any kind of exam. So it's so hormone binds, G protein is activated, adenylyl cyclase is activated, and then cyclic AMP is produced. This activated cyclic AMP then activates protein kinase A, and this protein kinase A causes a cellular response. All right. So there are two kinds of G proteins like GS and GI, and there's also GQ. But now let's discuss about GS and GI itself. So GS proteins stimulates adenylyl cyclase and then increase cyclic AMP, whereas GI protein inhibits adenylyl cyclase and decreases cyclic AMP. So GS is nothing but G stimulatory, GI is nothing but G inhibitory. So GS stimulates, GI inhibits. So uh, so this exam often tests which hormones increase cyclic AMP and which hormones decrease cyclic AMP. So we will be learning about this in a while. So the hormones that use cyclic AMP includes FSH, LH, ACTH, TSH, PTH, glucagon, calcitonin, and ADH. So the mnemonic for this is flat PGC, flat PGC plus ADH. So FSH, LH, ACTH, TSH, PTH, glucagon, calcitonin, ADH. This ADH acts on the V2 receptors, or the vasopressin receptors. So the clinical importance of cyclic AMP is that many endocrine diseases, most of the endocrine diseases, these involves defects in receptors or cyclic AMP signaling. So we need to understand that. For example, in uh, pseudo hypoparathyroidism, so the parathyroid hormone levels are high, but calcium remains low due to a failure in signaling pathway, like a failure in the cyclic AMP signaling pathway, or if there's a defect in the cyclic AMP signaling pathway, even though despite there being high PTH levels, there might be still uh, presence of low calcium levels in cases of pseudo hypoparathyroidism, because and this is most importantly because of a cyclic AMP signaling defect. Many endocrine diseases involve these defects in receptors of cyclic AMP pathways. So the cyclic AMP pathway is fast acting, as we've already discussed. It's a second messenger based, but and this is used by many pituitary hormones. So the cyclic AMP pathway is used by many pituitary hormones. We have already discussed like flat. What's that? Flat PGC plus ADH, FSH, LH, ACTH, TSH, parathyroid hormone, glucagon, calcitonin, and ADH. So we need to memorize this flat PGC, and whenever you see a question regarding hormone and receptor, we need to think about which receptor is being tested upon, which G protein is involved, and what is the second messenger. So now let's discuss about IP3 and DAG pathway. So this IP3 and DAG pathway uses GQ proteins. So we have already discussed. Apart from GS and GI, there's another G protein called as GQ protein. So this IP3 and DAG pathway uses those GQ proteins. So activation of uh, phospholipase C. This activation of phospholipase C leads to increased intracellular calcium, and this in turn leads to activation of protein kinase C. So now let's look at the basic sequence once again. So when a hormone binds a receptor, the GQ protein is activated, and because of this activation of GQ protein, phospholipase C is activated, and because of activation of phospholipase C, there is formation of inositol triphosphate and DAG, which leads to increased intracellular calcium. This increased intracellular calcium in turn leads to activation of protein kinase C. So when this protein kinase C is activated, there is a occurrence of cellular response. So the pathway is GQ activation, phospholipase C, IP3 or DAG formation, increased intracellular calcium, which leads to protein kinase C activation and cellular response. So, the hormones using this pathway, this IP3DAG pathway includes gonadotropin-releasing hormone, oxytocin, vasopressin, angiotensin II, and thyrotropin-releasing hormone. So, we can use a mnemonic GOVAT, GnRH, oxytocin, vasopressin, angiotensin, TRH. So, we also need to memorize this mnemonic of hormones that use IP3 and DHG, GnRH, oxytocin, vasopressin, angiotensin, and thyrotropin releasing hormone. So now let's discuss about and try to differentiate between IP3DAG versus cyclic AMP. So cyclic AMP uses protein kinase A, while IP3DAG uses protein kinase C. So knowing this key difference helps us identify uh, hormone effects quickly whenever we see a question on an exam. So this cyclic AMP uses protein kinase A, whereas IP3 or DAG pathway uses protein kinase C. So we just need to memorize this, and when there's a mention of protein kinase activation, which is leading to a cellular response in the question, you need to understand and remember that cyclic AMP, protein kinase A, and IP3 DAG, protein kinase C. Clinical importance of IP3 and DAG. So this pathway is associated with contraction and secretion. So this pathway of IP3 and DAG is mostly concerned with contraction and secretion. So whenever there's a calcium release, it affects muscle contraction, and muscle contraction from a gland leads to hormone secretion, and this hormone secretion leads to enzyme activation at the cellular level. So, oxytocin causing uterine contraction via IP3DAG is a typical example of is a classic example of this pathway. So, oxytocin is a hormone which acts via IP3DAG. And there's calcium release, and this calcium release leads to milk secretion. So it's like vasoconstriction occurs because of this contraction secretion mechanism. Uterine contraction occurs because of this contraction secretion mechanism by IP3DAG, and enzyme activation and milk ejection also occurs by IP3DAG pathway. So this IP3DAG pathway is calcium mediated. So this is fast acting and is important. This is important for vascular and smooth muscle effects. So this IP3 and DAG is mostly useful and needed for vascular and smooth muscle effects is what we need to remember. So it has a fast onset. It is fast acting and it has a shorter duration of action, and it shows its effects through a calcium mediated pathway. So now let's discuss about tyrosine kinase receptor pathway. So in this pathway, the receptor itself has enzymatic activity is what we should remember. So in this tyrosine kinase pathway, the receptor itself has an enzymatic activity. So after hormone binds a receptor, there is dimerization of receptor that is happening, which leads to autophosphorylation. And this autophosphorylation leads to downstream signaling. So this tyrosine kinase receptor pathway, the receptor itself has enzymatic activity. This pathway is used by growth-related hormones. Okay, this pathway is used by growth-related hormones like insulin and growth factors. So these growth-related hormones use the tyrosine kinase pathway where the receptor itself has enzymatic activity. So hormone binds a receptor, uh, there is dimerization of receptor, there is autophosphorylation of receptor, and then there is downstream signaling. So whenever you see growth, metabolism, and cell proliferation, you need to think about tyrosine kinase pathway. So hormones using tyrosine kinase. So hormones like insulin like growth factor 1 and growth factors like EGF and PDGF. So all these act through tyrosine kinase receptors. So insulin resistance, so this insulin resistance often reflects a receptor or signaling problem. So diabetes is not always because of lack of insulin. It might also be occurring due to insulin resistance at the receptor level or the signaling pathway level. So whenever there's uh, poor glucose uptake and high blood glucose levels, despite a high insulin level, you need to think about a receptor defect. And this insulin growth factor 1 and epidermal growth factor and platelet-derived growth factor, they mostly act through these tyrosine kinase receptors. Yeah. So uh, insulin resistance might be a classic example of this tyrosine kinase receptor resistance. So now coming to the JAK-STAT pathway. So this JAK-STAT pathway directly, this JAK-STAT pathway directly transmits. So this directly transmits signals. This directly transmits signals to the nucleus without the involvement of a secondary messenger. So this JAK-STAT pathway, what it does is it just directly transmits signals. We have discussed about cyclic AMP, we have discussed about IP3TAG, and we have discussed about tyrosine kinase. And now, when we discuss about JAK-STAT, the main differentiating factor is that I need to let you understand that the key point here to note is it directly transmits signals to the nucleus without the involvement of a second messenger. So this JAK-STAT pathway is mainly used by cytokine-like hormones. So the mechanism is the hormone binds the receptor. This JAK activates STAT. This STAT enters the nucleus and this alters gene transcription. There is no involvement of second messenger and there's direct signal transmission to the nucleus without the involvement of a second messenger. So when the hormone binds to receptor, this JAK activates STAT. STAT enters the nucleus. This STAT enters the nucleus, but there is no second messenger here. The STAT itself enters the nucleus and it alters the gene transcription. This is mainly used by cytokine-like hormones. So hormones using the JAK-STAT pathway includes like growth hormone, prolactin, erythropoietin, and cytokines. So all these use JAK-STAT pathway, growth hormone, prolactin, erythropoietin. So these use the JAK-STAT pathway. So the mnemonic to remember these hormones is GTE. So the key point that we have to remember is that the growth hormone does not use cyclic AMP and the growth hormone uses JAK-STAT. Growth hormone uses JAK-STAT pathway. So now let's discuss about cyclic GMP pathway. So hormones like ANP, BNP, and nitric oxide. So these hormones act via cyclic GMP. So this pathway causes vasodilation and smooth muscle relaxation. Cyclic GMP pathway, the mechanism of action is that the hormone increases cyclic GMP levels, and this activates protein kinase G. So we have all, and now this is another protein kinase. We have discussed about protein kinase A, and we have discussed about protein kinase C. So now we have protein kinase G here, and this activation of protein kinase G occurs because of release of cyclic GMP. Okay. So the hormones using the cyclic GMP includes atrial natriuretic peptide, brain natriuretic peptide, and nitric oxide. So these can cause vasodilation and smooth muscle relaxation. Now let's discuss about intracellular or nuclear receptors. So lipid soluble hormones. We have discussed about lipid soluble hormones. They bind the intracellular receptors, and then after these lipid soluble hormones bind the intracellular receptors because they cross the cell membrane, they alter gene transcription. So this is the most important thing. And depend on their effects depends on new protein synthesis. So their effects depends on new protein synthesis. So whenever lipid-soluble hormones cross the cell membrane and acts on the intracellular receptors, it binds to the receptors either in the cytoplasm or on the nucleus. So what happens is that hormone receptor complex, this hormone receptor complex binds to the DNA and then alters gene transcription. And the effect of these lipid-soluble hormones depends on new protein synthesis. Hormones using nuclear receptors includes all the steroid hormones like cortisol, aldosterone, estrogen, progesterone, testosterone, and thyroid hormones like T3, T4, and vitamin D also acts via nuclear receptors. So all these are lipid soluble. Though these thyroid hormones are more like amine hormones, they act more like steroid hormones. So the hormones that act via intracellular receptors include steroid hormones like cortisol, aldosterone, estrogen, progesterone, testosterone, and thyroid hormones, and then vitamin D. Why do nuclear receptors act slowly? So these hormones have delayed onset, but they have a prolonged effect because gene transcription. So gene transcription is something that is involved here, and when gene transcription is involved, it takes some time for it to show its effect. So the characteristics include slow onset of action, long duration of effect. The effects persist after the hormone is gone. These nuclear receptors cause gene transcription. So this gene transcription takes time, so it is delayed, but it has sustained clinical effects. And withdrawal of these lipid-soluble hormones definitely takes some time because gene transcription is involved. So let's discuss about hormone binding proteins. So many hormones circulate bound to carrier proteins which prolong their half-life. Uh, so many hormones, they don't just circulate freely, so they bind to a carrier protein and then they circulate in a bound state to a carrier protein. So this binding with the carrier protein helps to prolong its half-life in the bloodstream. Okay, so only the free hormone is biologically active, but the hormone that is bound to carrier proteins or hormone binding proteins is not biologically active. Only the free hormone is biologically active. So the examples of these hormone binding proteins includes for thyroid hormones, it is thyroid binding globulin. For cortisol, it is cortisol binding globulin. For sex hormones, it is sex hormone binding globulin. Okay, so the bound hormone acts as a reservoir and prolongs the half-life, whereas the free hormone is biologically active and it causes a clinical effect. Clinical importance of binding proteins. So changes in binding proteins affects the total hormone levels. Whenever there's a change in the binding proteins, it affects the total hormone levels, but it does not influence the levels of free hormone. So symptoms follow uh, uh, when the free hormone level decreases, the symptoms of hypo would occur. When the free hormone levels increases, the symptoms of hyper would occur. But these symptoms do not depend on the total hormone levels. It depends on the free hormone levels because the clinical effect depends on only on the free hormone, whereas the bound hormone that is bound to binding proteins is mostly acting as a reservoir and it helps in increasing the half-life, but it does not show any clinical effects. Total hormone level may be misleading. Free hormone determines the clinical effect. So in pregnancy, there is an increase in the levels of binding proteins, and so there is an increase in the level of total hormone, and there is reduced free hormone. So mostly it could be causing conditions like hypo conditions. In liver disease, there's a defect in synthesis of proteins, and there's a reduced binding proteins, which leads to reduced total hormone and increase in the levels of free hormone. So symptoms follow free hormone levels, but not total hormone levels. Let's discuss about negative feedback in this part. So most endocrine systems are regulated by negative feedback. So whenever there's a loss of negative feedback, that's the basis of many endocrine disorders. That's the basis of many endocrine disorders. When there's a loss of negative feedback, it's a basis for endocrine disorder. Most of the endocrine systems are regulated by negative feedback. Negative feedback is the key feedback mechanism in our body. So when a hormone level increases, the target hormone increases. So this target hormone uh, gives a feedback that it needs to suppress further release. So hypothalamus. Uh, so when there's an increase in T3 and T4 levels, there's feedback that is telling that you should reduce the thyrotropin releasing hormone, and this decrease in thyrotropin releasing hormone in turn leads to reduced thyroid stimulating hormone. And so whenever there's increase in T3 and T4, a negative feedback mechanism starts at the level of the thyroid, and then it reduces the TRH and TSH, which leads to reduction in the T3 and T4 levels. So whenever there's a loss of this negative feedback, there's a possibility of an endocrine disorder. So, when we try to discuss and differentiate between primary and secondary disorders, the primary disorder is something that is arising from the gland itself. There's a problem in the gland, whereas the secondary disorders arise from the pituitary dysfunction, or pituitary problem. Tertiary disorders arise from hypothalamic dysfunction. Primary disorder, there's a defect in the gland. Secondary disorder, there is a defect in the pituitary. Uh, and tertiary disorder, there is a defect in the hypothalamus. So negative feedback explains us the lab patterns, and it helps us differentiate between primary and secondary disorders, whether primary hypothyroidism or secondary hypothyroidism. You can just differentiate it uh, depending on the lab patterns and the feedback mechanism. So if it's a primary disorder, there's a defect in the gland. If it's secondary disorder, there is a defect in the pituitary, and if it's a tertiary disorder, there is a defect in the hypothalamus. So some hormones require, pulsatile secretion to function normally. So when there's a continuous exposure, it can lead to down regulation of a receptor. So we few hormones need pulsatile hormone secretion to elicit a normal physiological action. So examples includes gonadotropin releasing hormone and growth hormone. The key concept here is that continuous exposure leads to down regulation of receptor, whereas pulsatile release, just giving it in pulses, not instead of giving instead of releasing all the hormone at a time, which can lead to down regulation of the receptor, the gland just releases hormones in a pulsatile manner, in a pulsatile fashion, so that it would lead to uh, uh, normal physiological action and reduce the risk of receptor downregulation. So, whenever you give continuous GnRH, so this continuous GnRH could lead to a reduced LH and FSH, whereas when we give uh, uh, when we give GnRH in a pulsatile manner, there can be increased LH and FSH with respect to increased release of GnRH in a pulsatile manner. So, when you give continuous GnRH, what happens is there is down regulation of these receptors and the pituitary and the hypothalamus, and so it would lead to reduced LH and FSH. So certain hormones, they follow a daily rhythm which is called as the circadian rhythm. So examples includes that cortisol, which peaks in the early morning. Cortisol peaks in the early morning, while growth hormone peaks during sleep. So sleep is very important for growth of any child or person. So whenever there's sleep disturbance, there is derangement of this growth hormone, and that's the reason why everyone tells that sleep is the most important factor, and it helps your body to just grow or recover from the previous day. Cortisol peaks in the early morning, whereas growth hormone peaks during sleep. So, whenever we test these hormone levels, we need to understand that timing of the testing matters in any endocrine disease. So, you should test for cortisol. You should test for cortisol in the early mornings, whereas you should test for growth hormone during sleep. So, the abnormal timing could lead to uh, a false disease. So, yeah. final takeaway is that this, endocrinology becomes simple uh, when you understand, signaling. You have to understand signaling. You need to understand how the receptors work and what's the feedback pattern. So this foundation, helps us solve questions logically rather than just memorizing. You need to understand, hormone classification, location of receptors, signaling pathways, binding proteins, and feedback mechanisms. And when you understand all of these, it it allows you to solve endocrine questions. You can approach them logically rather than just memorizing tables. So in the next coming parts of the series, we'll go in a pattern which helps you understand the classification of a hormone, the location of a receptor, what's the signaling pathway involved, and if there's any hormone binding protein involved, what could happen with an increased pre-hormone level, what could happen with an increased total hormone level, and what are the feedback mechanisms, what are different kinds of feedback mechanisms. Now, we have discussed that negative feedback mechanism is the most important and most clinically relevant. Along with that, we also need to understand there are different other kinds of feedback mechanisms. So when you try to understand these, solving an endocrinology question becomes easy. So in the next coming videos, we'll try to just go through each gland separately, and we will be discussing each gland systematically. We'll be going like embryology and anatomy, physiology of that gland, different kinds of pathological conditions, and also uh, drugs that are involved with the changes in that gland, drugs that can be used to treat conditions related to that gland disorders. All right. So before ending the video, I would like to request every one of you to keep to subscribe and keep supporting. So this is an series uh, which is started with a motto that we need to end a burnout of passive lectures and uh, increase our time towards active learning. So I'll take a leave for now, and I'll get back to you very soon with other parts of our endocrinology series. Thank you for watching and keep supporting. Thank you.